Okay, so I'm going to be talking about advanced care planning, and I really want to thank the IMF for inviting me to come and talk to everyone about this. I'm very passionate about feeling this is an important subject for all of us. Little information about me: I've been a nurse for about 27 years. I spent 14 years in bone marrow transplant, which is where I really got interested in multiple myeloma, and I helped lead a support group in the Kansas City area for multiple myeloma patients. So the question is, what is advanced care planning? People often really don't understand this term. It's really just discussing and deciding what sort of care you would want if you became unable to speak for yourself, and being certain that the people who would make decisions for you are both identified and know what your wishes are, and would also be able to carry out those wishes for you. Keep in mind that this is something that goes into effect only if you become unable to speak for yourself. And people often think that that's something, well, that's never going to happen to me, but it's really not uncommon. Especially a myeloma patient may have often been too ill to really be cognizant, or maybe you've had surgery and during that time you certainly weren't able to speak for yourself. If you've had a colonoscopy, you've had time period there that you were unable to speak for yourself. And in a lot of those situations, it's unlikely that something emergent is going to happen, but it can. It's important that someone's identified as your spokesperson and that that person knows your wishes. So do you have an advanced directive? Lots of times people have completed a will, and when they've completed the will, they may have completed a health care and financial durable power of attorney. They may have also completed a living will. A living will is a great way to identify what your wishes would be. So for a lot of people, this is kind of a place where they'll start thinking about what sort of care I would and would not want. But for a lot of us, we really don't fully understand what the options are. And medical care becomes more complex every day. So that the options that were available 5 years ago, there's an entirely new set of options. So it's important that you kind of know what's available and what would I want. This is an example of a healthcare power of attorney. They vary from state to state, and I have with me today out in the lobby area some copies of the California Healthcare Durable Power of Attorney. This is the document you use to identify the person who would be your spokesperson. Now, one of the things that is important to keep in mind is that this person is able to carry out your wishes. Sometimes, if we're talking about somebody that we're extremely close to, like a spouse, sometimes it's hard to carry out the decisions that that person may want. Because as their spouse, you want to do everything to hold on to them. Or perhaps you have a marriage like I have, where I'm the decision maker in our household. I'm pretty sure that if I became unable to speak for myself, my husband would wait for me to wake up to make a decision. That's just who he is. So as a result, my husband's not my spokesperson. I have a good friend who is my listed spokesperson. A little more information about understanding what your wishes would be. One of the things that comes up is code status. Now, a lot of you, if you've been in the hospital, they've probably asked you, what's your code status? And you think, what does that really mean? Your code status means, if I were to pass away, if I died, would I want to be resuscitated? And people are often kind of shocked by this idea that CPR has to do with having died. But the reality is that CPR is not something that's performed on the living. It is only performed if you are not breathing and you do not have a heartbeat. This right there tells us the reason that these decisions need to be made in advance. If you're not breathing and you don't have a heartbeat, you can't say whether or not you want this type of treatment. You can't say, yes, I want CPR, or no, I don't. That's the reason that CPR is one of the few medical treatments that by default is done. It is performed. So if you don't want to have CPR performed, it's very important that you have that identified and that your loved ones know what your wishes are. One of the frustrations I hear from patients is every time I go into the hospital, they ask me this question. I have to have this conversation over and over. That's because when you're in the hospital, that code status only is alive while you're in the hospital. When you're discharged, it expires. It's not transportable from the inpatient setting to the outpatient setting. And there are starting to become documents available that are transportable. And in a moment, I'll talk a little bit more about those. The other question in healthcare is how aggressive you want to be. Because there's this question about a do not resuscitate. But the reality is that there is lots and lots of healthcare that happens long before a person codes, before a person goes into cardiopulmonary collapse. There's all kinds of meds, therapies. Perhaps you're going to be put on a ventilator, go into the ICU. It's important that you know what these options are and whether or not those are things that you would want to take place. So we'll talk a little bit more about CPR. Again, I mentioned the fact that CPR has only happened if you're not breathing, you don't have a pulse. If there's anyone in here that's done CPR training, you've had to do that thing where you run up and you say to the mannequin, Annie, are you okay? If Annie responds, we don't give her CPR. If you don't want to have CPR, though, if Annie didn't want to have CPR, she better have completed a do not resuscitate order ahead of time. And this is an order that needs to be done with a physician. It needs to be done with a physician for two reasons. One is that it's a physician's order. So it definitely requires a visit with your physician, a discussion with your physician, and that physician's signature. The other reason that it requires a physician involvement is that it's an important question. And your doctor is the person who's going to be able to provide you with important information to give you the perspective and help you understand what's the right decision for you. The one thing that I try to make people aware of is this is a very personal decision. It's not that you should do what anyone else thinks you should do. You shouldn't be making a certain choice. This should be the choice that is correct for you. You are allowed the choice of allowing a natural death, which is what happens if someone does not have CPR. You are also welcome and able to choose to have the most aggressive of care. It's what's right for you, it's what's right for your loved ones, and it's important to have that conversation. So a little bit more about what all the levels are of medical care before CPR. And there's a lot of great detail here. One of the forms that I have with me today is that out-of-hospital do not resuscitate order, and it has all the more specific details here about full treatment, mid-level treatment, best supportive care. And one of the things that is really important for people to understand is that a person can choose to not have resuscitation, choose a DNR order, and yet still want the most aggressive of care. And by that I mean is as long as you are alive, breathing, and have a pulse rate, you can choose to go to the ICU, be on a ventilator, have all the most aggressive therapy. I find that people are often very concerned that if they choose to be a do not resuscitate, that then they're just going to be left in a corner and not get any care. And that's not at all true. And in today's medical world, we give tons of treatment, keeping people from progressing into a cardiopulmonary collapse. I mentioned earlier about the fact that do not resuscitate order expires each time you get discharged from the hospital. And for a long time, all there was a simple do not resuscitate order. It only addressed whether or not you wanted to have CPR. It was called an out-of-hospital do not resuscitate order. Now there are starting to be more technical options, again, because there's just so many more options in healthcare. It does, again, require a conversation with a physician and a physician's signature. Most states are now developing different types of transportable forms. In the state of California, it is a POLST, which is a physician order for life-sustaining treatment. And I have an example of the form out there if you're interested in seeing a copy of it. If you're interested, I encourage you to pick one up and then plan a time to talk to your doctor a little bit more in depth about this. It provides more control over all the various options for people who have a serious illness, are at a high risk of developing complications. So once you've completed all these forms, people are often confused about what they should do with it. We have this tendency to think, this is an important form, I should file it away someplace. They want to put it in their safety deposit box, they want to put it in their filing cabinet. But the thing is that in case of an emergency, what you need is to be able to get your hands on that document quickly. People who work as emergency care providers, EMS, that type of thing, they've been taught to look a couple of places for documents and medications: bedside table and the refrigerator. So we lots of times encourage people to put these documents in an envelope and stick it up on your refrigerator. Then, if you're found down, your loved ones are able to go, wait, Mary has a form on the refrigerator to address her wants in this situation. The other thing that happens these days is that life is just more complicated in the computer age. And not only is life more complicated, but death is more complicated. Most of us have all kinds of things on our cell phones. We have photos. We have all these online accounts. We probably pay bills that way. If you're too ill to be able to make your medical decisions, you're also too ill to be able to pay this month's electric bill. So it's very important that someone knows how to access your phone, and that there is someone you trust that you share your codes with, the passwords to all of your accounts. All of this is good information for you to have. The most important part of all of this, though, is conversation. What matters the most is the conversation that you have with your loved ones, with your friends, with your physicians and other healthcare providers. It's important that you're able to talk through what's important to you and that they understand. It's comforting for your loved ones to be able to say, I know what Bill wanted in this situation. It might still be really hard for them, but they're confident that they are carrying out your wishes. So what really matters is for you to have this conversation. And I know it can feel really awkward, but I encourage you to just kind of find a time. Interestingly enough, there's a big push for this to be Thanksgiving conversation. The family gets together and they talk about these things. Fortunately, there are a lot of great online resources to kind of help. I recommend prepareyourcare.org. It has options for multiple states. You can choose the documents correct for your particular state. And it also helps you work through all of these questions. You can work with your loved ones and go through these things, and you end up with some completed documents on both what would be your preferences and identifying your healthcare providers, your healthcare decision maker. Another big thing nationally is April 16th is National Healthcare Decision Day. You can usually find a lot of options online. This particular project is the Conversation Project, has National Healthcare Decision Day. Out at my table today, I have some cards called Go Wish cards, and I welcome you to come out and pull a card. What you do is you look at that card and you think, is this something that would be important to me if I were at the end of my life? And it's again like that thing that we mentioned, that Teresa mentioned earlier. We have this tendency to think that everyone feels the same, but they don't. So you need to kind of look through things, decide, is this important to me, and just get conversations started. Also, if your cancer center has a social worker, they are a great resource for this type of information, for helping encourage these conversations, helping you complete your healthcare durable power of attorney. So I just ask all of you to recognize that the time to plan is now. Nothing about this is actually scary. Planning is something that is very adult. It's something that we normally do all the time. We plan for funerals, we plan for weddings, we plan for a baby, we plan for education. Planning for our health care is something that we should all do as well. And I just encourage you to get educated and recognize this isn't as scary a topic as you might think. Thank you.